Can you introduce yourself, your name, and a bit about what you do and your role?
Okay. Well, my name is Sid Akrell. I'm the Chief Nursing Officer for a care provider in and around the Yorkshire area. We have 5 very large homes. One home in particular in York is 108 beds. So we have a mixture of nursing residents and people who are deemed to be residential. During this last lockdown, the guidance has changed slightly, and we have been able to facilitate more visits within that guidance as well. At the moment, people are able to access a window or a garden visit, a visit in the visitors' room, and so these visits do not require a test to be completed. If we've looked at all the other options and that they're not available, then we can facilitate in-room visits for people on the grounds of compassion or essential. And we are now able to allow people to have a test to check that they're negative, free of COVID, before coming into the home. Within our group of homes, we do ask our relatives to undertake a PCR test. So that's offering them the same level of protection that myself and colleagues have once a week. And then the government have introduced the lateral flow test. So as they enter, they also have a lateral flow test. I know that some care homes are worried that if they test positive, then that will count towards an outbreak. And as we know, during the pandemic, it's 2 suspected or 2 confirmed cases only, which is a very low number, but for obvious reasons. Now, those conversations need to be had with Public Health England and the local authority and everything. I do not believe throughout our homes we've had anybody test positive on the PCR. If you put your case, then they should not count towards your outbreak status whatsoever. And I generally find that I think the relatives, the visitor, poses less risk than some of my colleagues, because with the greatest will in the world, you know, we are dealing with many different people. And we're very mindful and very conscious of all IPC measures. But the relative, their loved one, is the most important person. You know, they want that. So when we've been asking people, you know, please be mindful, please look at your behaviours, limit your contacts, do these things well, but think about safety when you're coming to visit your loved ones. They want to do that. They will absolutely do everything that's been asked of them, because the safety of their loved one is paramount. Now, throughout the pandemic, I've always been very, very clear, and I had the full backing of my board. We would always facilitate compassionate visits for perhaps end of life or essential visits, because some of our people have dementia. So this long separation for them has been very, very difficult. And in my mind, that would class as an essential visit. Often there's a group of people who have been forgotten or you know, couldn't facilitate or couldn't access some of the visits. So, for example, they weren't able to go to a window, or they may be on the 3rd or the 4th floor. We couldn't take them to the visitors' room because predominantly they were nursed in bed or in their room because of equipment, and they might not meet the criteria for compassionate visit. Now, we've stretched that a little bit, because surely that must be an essential visit. We've considered all the other options, the least risk possible, and this must be an essential visit. We would deem an essential visit to be, for example, we had a young man who became very distressed, very upset, started displaying some behaviours he hadn't previously. So we were able to, via risk assessment and talking with the family, including the resident and colleagues, we were able to arrange for the daughter to come and take the young man out for walks and to spend time with him. So it was always the least risk possible. Another lady who became quite distressed, we saw an increase in falls. She wasn't communicating as she previously had, and we were very concerned about her emotional well-being. And her husband actually approached us because obviously we were contacting him about some of the incidents, and we came up with a plan. So he came onto our surveillance testing with the PCR, and we risk assessed again, had a look at the individual circumstances, and that gentleman has continued to visit his wife throughout the pandemic with very good effect, actually, when we've looked at the evidence of the incidents reducing. We can evidence that very, very well. Sometimes, you know, there may be other reasons. Often our relatives have previously come in to support around meal times, encouraging people to eat, enhancing the dining experience. And some of our residents, we noticed, were perhaps losing weight, weren't responding to us as they would do a family. So we've contacted the family, and this has been classed as an essential visit, where family have come in to assist within that process again, to helping the person over meals with the food intake. It might be that people have come in, you know, daily to be with the loved one, or, you know, they have stayed with them, and we've always been, quite rightly, fully behind that approach. I haven't seen an increase of infections because of that approach, and I haven't seen anyone harmed, and I haven't seen anybody objecting, or, you know, because that affects other relatives as well. I wrote to all our relatives, and I discussed everything with the colleagues and the board, and contact, we wanted contact because, you know, I can appreciate, as I've said, I'm a mother and a daughter and a wife, and not to have that contact. I understood that with my own dad. But I wrote to all the relatives to explain about this and about the lateral flow test and about the PCR. And I just explained that I thought it was too risky. So we couldn't be kissing, and we shouldn't be hugging because the tests weren't that accurate. And I was worried, and everybody has fully embraced that and gone along with it, and is very understanding of that. So I did say, you know, it would be nice if people could hold hands. I can see that that's not enough, and it must be heartbreaking, but it's something, it's a start, and we can do that safely because people could have gloves on, we can wash hands, we can manage that. Again, it's clinical, but with good intention, and to keep people safe. So initially we were asked to look at each resident, work with the resident to determine if they wanted visitors and explain the risk to them. So within the care plan, that information is in there. So within the care plan, we do have documentation which would indicate our considerations for that person in particular, and also for the type of visit that might be best for them. Because I think I've touched upon, somebody who has to be cared for in bed might not be able to access a window or a visit in the visitor's room. So we look at the least risk, but then to facilitate a visit for that person, either for compassionate or essential reasons, or when, you know, visiting's been a little bit more freer, less restrictive, we look at the needs of that person and then formulate a risk assessment around that. So we've got different risk assessments, some generic, and the basis is generic. And then we build on that around that person as well. And we include them as far as we're able to. We're always mindful of the Mental Capacity Act, following best interest and including everybody in those decisions, but also the Human Rights Act. the right to family life. We considered that. And I think, you know, as we've pieced together bits of the jigsaw, this has been very beneficial to colleagues interpreting information, and also for residents and their relatives as well who have benefited. I appreciate it's been very, very difficult for the families, and we've tried to involve them as much as we could. I think in the early days, they were neglected because we had such a massive job on our hands, especially either trying to keep the infections out of the homes, or we were dealing with the infections in the home. And, you know, we were hit very hard by that. On occasions, families have wanted to challenge the guidance or the information, quite rightly, and with the best intentions. I've just wrote to the families again to say, you know, contact the home manager, see what type of visit you can have, look at the risk assessment again. And you know, now we don't only have to consider end of life in those last few days or weeks. I think the sensible approach would be to introduce things slowly. So I would like to see visits being conducted in a nice room, with some contact, with the necessary precautions in place. But going forward, there will be a long period of surveillance, of watching and monitoring to make sure that, you know, any infections spotted early and dealt with, and that we take the necessary precautions and restrictions at the time that we have to do. I think the basis is to start and have a look, and what I've always tried to do is have a look at the guidance and see where we can fit in or around that. Look at the documentation and risk assessment, which it's not just a tick box. There can be no blanket approach. There has to be that individualized care, person-centered for that person. And I think that's the starting point. I think to start with that risk assessment, looking at the individual, how can we facilitate safely and get everybody on board with that, and the least risk possible option.